I'm conscious that obviously there's quite a lot of you that signed up to this webinar, so that's absolutely brilliant. So there are people still popping up as joining, so Laura is going to carry on admitting people to the group. So thank you so much for taking the time to join us. I've seen some of the names and job titles of the people that have joined, so we've got a really wide range of clinicians, which is absolutely fabulous. Obviously, as Laura says, keep your microphones on mute for me. Otherwise it just obviously interferes in everyone's sound. I'm Sharon Gardner. I was previously a TVN at the Christie, and I've got quite a lot of other sort of clinical and wound care experience. As I've already said, we've got absolutely loads of you on this call, which is amazing. So please do use the chat box at the top to ask questions, or more importantly, because we know the research around radiotherapy-induced skin reactions, which we'll discuss further, please do share any best practice that you've got going on in your areas. We've got some radiographer team members on here. We've got some oncology team members. I do recognise some of the names. So please do share any best practice with us. Use this opportunity. So I'm going to share my screen now, start the webinar, and obviously Laura will continue to admit people and man the chat box. Okay, I'm assuming you can all see my PowerPoint screen. Please, someone just let me know. I can only see Laura, so please do let me know if you can't see it. So once again, welcome to today's session on radiotherapy-induced skin reactions. So just as a quick sort of introduction, and obviously this is by no means a teaching session on radiotherapy, and as I say, looking at some of the people that are on this webinar, you know, you would absolutely be able to run this slide a million times better than me. But for those people on the session that obviously aren't in areas of radiotherapy, may not be seeing radiotherapy-induced skin reactions a lot, I just wanted to be able to do this as a scene setter. So obviously from a type of radiotherapy point of view, we've got our external beam. So what we may traditionally think about in terms of radiotherapy treatment, so the big machine that we know aims the radiation at the cancer. We know the machines are large, they're usually noisy. We know that obviously it can be quite difficult for patients because they've got to be held still to have the treatment. So, you know, they have to be held still on the treatment couch. We've also got internal, so where a source of radiation is put inside the body. And it may well be that the source of radiation is solid, so like an implantable item, or maybe a liquid. Brachytherapy that you can see on the diagram there is a type of internal radiation. And we know that obviously the radiation can come in the forms of seeds or ribbons or wires, and they may be left in the body for certain periods of time, depending on the treatment time. Obviously, proton beam, if you work in oncology, you will know proton beam. If you're local to Manchester, you may have heard of it because obviously the Christie Hospital a few years back were lucky enough to get a proton beam there at the Christie. When I was there, we had to send patients, usually children, abroad to undergo proton beam therapy. So there's a lot of work going on around proton beam. It is believed that proton therapy is safer and more effective. So as with your external beam radiotherapy, obviously the radiotherapy goes through, external tissues, hits the tumour site within the body, and then does carry on a little bit sort of through the tumour site. So you can get kind of some radiotherapy-induced skin reactions kind of at your exit site. Proton beam stops directly and kind of encases the tumour with the proton, so it stops at the tumour. It is thought, obviously, that this is safer. It's a more directed approach to get into the tumour. But it's also, there is some research that suggests that due to the levels of energy from proton beam, that the radiotherapy-induced skin reactions may be more severe. As I say, this was just as a scene setter kind of thing, introduction. So let's think about radiotherapy-induced skin reactions. And I know quite a few of you on this call will be actively treating patients with skin reactions or have seen a significant number. And obviously during the session, we're going to talk about why skin reactions happen and what that actually means to us as clinicians and what it means to our patients. But we know patients will often describe a radiotherapy-induced skin reaction as a bit like sunburn, because really, if they've never had anything else, it's a difficult sensation to be able to describe if they've never felt anything similar. So, we've got a definition there: redness, itching, burning, soreness, peeling, blistering or darkening of the skin, so changes of the skin pigment. And we know this can happen gradually over the course of treatment and may only happen in certain areas, or it may well be that there are certain areas that would be more significant in relation to how that skin's going to react. We also know that skin reactions from external beam radiotherapy are one of the most common side effects from treatment and are a factor which could limit dose, alter treatment schedules, have a significant impact on that patient's quality of life and how they're able to tolerate continuing with their radiotherapy. So why is it important? Well, as I say, we know that it's a significant number of patients that experience some skin changes, so 95%, as we can see there. We also know that prevalence is higher in patients receiving treatment for head and neck cancers. So 25% of those patients will go on to develop a severe radiotherapy-induced skin reaction. And obviously, as I said previously, there are certain treatment areas, so maybe your breast area if there's significant skin fold, or maybe your perianal, your vulval sort of genital treatment areas that we know are probably more prone to developing severe skin reactions. And really, why is it important? Well, it can have a detrimental impact, can't it, on overall outcomes. So specifically, the patient experience and their quality of life. We know patients undergoing treatment for cancers, they will absolutely want to carry on because, the ultimate aim is for them to improve their length of life or definitely heal them from a cancer point of view. So they will really, really try and continue with treatments. But then if they're having this discomfort from the skin reaction, then obviously that's going to have a real impact on quality of life, which, as I've said, can then delay radiotherapy or delay sort of treatment schedules and doses. So a little bit about actually what causes someone a greater risk of developing a skin reaction. What are those factors? So obviously there's the internal factors, so the kind of things that we can't really change at the point of treatment, like patient demographic or disease-related characteristics. So it depends on the disease, depends on the tumour type, depends on what other treatment's going on. Unfortunately, we know as we age, skin integrity, skin laxity, its ability to regenerate and repair itself. Unfortunately, we know aging is a blessing, but unfortunately, in terms of our skin integrity and treatments we may need, it does have a negative impact. Unfortunately, hormonal status we know, so we know certainly women on the call who may be menopausal age or postmenopausal age, we know that obviously estrogen, for example, does have an impact on skin integrity. There's quite a train of thought and research around ethnic origin having an impact, although it's unclear whether paler skins or darker skin tones do increase risk looking at the research. Obviously, smoking, we know from looking at a lot of the data around the burden of wounds that Julian Guest has produced over the years, we know that smoking is the main common theme that links a lot of non-healing wounds. So we know that smoking has a significant impact on skin integrity. And then obviously all the other implications around coexisting disease, polypharmacy, multiple medications, multiple interactions. There's a lot of internal factors that would increase someone's risk. And then obviously we've got the external factors. So those are the treatment-related ones that influence the delivery of therapy. So they'll include things, there's the treatment dose, volume, fraction, the time span of treatment, site of treatment, the beam energy, and obviously any concurrent chemotherapy treatments. So it's really important that the goal is good skincare. So it's good skincare from the offset and any strategies to try and delay the onset of skin reactions or indeed reduce the degree of reaction that they may experience. So thinking about the pathophysiology, and again, this is just a very, very basic descriptor because obviously we want to talk about what the treatments for the symptoms are. But why does radiotherapy damage the skin? Well, we know that radiotherapy uses ionizing radiation to kill the cancer cells because it causes irreparable damage to the DNA. We know that obviously radiation is able to affect the material that it passes through by disrupting its atomic and molecular structure, causing that instability. Obviously, as the radiation passes through the cell, it damages the DNA by direct and indirect action. So obviously, as it says on the tin, basically, direct action describes the damage caused by the effects of the ionizing radiation. So the actual physical damage on the atoms and the molecules contained within that DNA. The indirect action occurs when the radiation interacts with water and oxygen molecules in the cell to create chemical changes that cause further DNA damage. And obviously, as a result of the combination of the direct and indirect action, we know that most cells don't die immediately, do they, after that initial radiotherapy damage? They will continue to divide a little bit before then they obviously die off. And this obviously explains why some side effects are delayed. So this is one of sort of the explanations of why some of those side effects aren't seen immediately, or the full effect of radiotherapy on the cancer, the effectiveness of treatment, and indeed the reaction on the skin can take some time to be revealed. So this is I love this image because it really explains why we see those skin changes through the cycle of radiation. So why do we see things changing throughout the treatment? So we know, looking at the image, that radiation impairs stem cell division within the basal layer of the epidermis, disrupting or sometimes halting the normal process of skin regeneration. So if you think those basal cells in the basal layer, they are undergoing damage from the radiation. So they're a little bit damaged, aren't they? They're a little bit broken. So they're starting to migrate up and they're trying to get up to the top here where they're still a little bit damaged and a little bit unhappy. So by the time those first damaged basal cells reach the surface, as you can see from the image there, where our yellow arrow is, so about 10 days from first treatment, that's when our first sort of cohort of basal cells, if you like, have managed to migrate to the skin surface. And that's obviously where we see the erythema. So that first stage of the acute radiation reaction, just caused by that skin being exposed to the radiation. Obviously, we know erythema is characterised as that reddening, so that pink or reddening, and obviously paler skin tones. Obviously, if you've got a patient with darker skin tones, you will see some pigmentation changes. You obviously won't see erythema as you would in paler skin tones. The change is caused by dilation of superficial capillaries as an inflammatory response to that basal cell damage. And obviously we know that erythematous skin can feel hot, itchy, just a little bit uncomfortable itself. Obviously, we will continue to expose these cells in the skin to the radiation as we're continuing to treat the patients. And as you can see, obviously, round at the bottom, we're still treating. The damaged basal cells are trying to repair themselves. We're trying to get nice, healthy, good cells that are migrating up, but we're treating at a faster rate than the basal cells can regenerate and migrate up. So then you'll see that further skin damage change. So you'll see that dry desquamation that we can see at the bottom of the image. And it may well be that as we're treating, we've still got a bit of erythema. We might have a bit more brighter erythema, very different skin changes, but we've now got tight, dry desquamation. Again, we're continuing to treat. These basal cells are continuing to try and regenerate. And then obviously, as you can see from the green arrow, we're now getting moist desquamation. So we've probably got a little bit of everything going on now. We've probably got a little bit of dry, erythema, bright, tight, painful, itchy, and we've now got moist, broken areas. And again, it's just because the basal layer is producing insufficient cells to replace those that we've lost. So obviously, you know, the epidermis is becoming denuded, the dermis is becoming exposed, and the skin will become inflamed with areas of blistering and possibly ulceration. Obviously, these patients, there is a great risk of infection. And, you know, as I said earlier, there's usually a point here now where patients are feeling significant pain, significant discomfort, and are requiring analgesia to help manage these symptoms. Obviously, in an ideal world, we've then had our treatment finished. manage to continue through the treatment, whatever has been prescribed. And then according to the cycle of radiotherapy, about 10 to 21 days after treatment is when we are then getting our healthy, untreated basal cells that have migrated up, and we should start seeing improvement in that skin reaction. So when we talk about radiotherapy-induced skin reactions, we talk about RTOG. So we use a grading tool called RTOG, and I will go into these a little bit more detail in the next slides. So obviously it starts at 0. Visible changes, no visible changes to the skin, and it's recommended that skin is assessed weekly. These guidelines are cited from the Society of Radiographers' most recent skincare guidelines, so you can find them in there in relation to recommendations around assessment. So RTOG 0 to RTOG 4. So what do they actually mean? So obviously this is just broken down in a little bit more detail so we can see our observations. So what is the skin looking like and what would we grade it as? How often should it be being reassessed? And please feel free, you know, as I said earlier, please put comments in the chat box if you do something different that you found that's worked for you. And then you can see there we've got intervention recommendations. The intervention recommendations are taken again from the Society of Radiographer guidelines, but also from the Royal Marsden online handbook, which are both 2020. So in terms of intervention, obviously prior to treatment and at RTOG 0, patients are advised to continue using moisturising products, so preferred products. So if they're already using a good moisturiser that is sodium lauryl sulfate free, then it's recommended that they continue to do that. And obviously if they're not already using one, advise them to start. There's also a lot of advice around encouraging self-care guidelines, information leaflets, so that patients know what to refer to in terms of expected outcomes for their skin reactions. Obviously, you can see there RTOG 0 steroid or cortisone creams. That is taken from the Royal Marsden. So there is some recommendation around steroid or cortisone creams as a prophylactic treatment, but I am going to come on to that in a little bit more detail when we look at what the research has shown us. And as we know, those of us that work in oncology or radiotherapy, research is a little bit sparing in some areas. So as I've said, please share best practice because this is the perfect platform to do it. Obviously, we can then see if we refer back in our minds to the cycle of radiotherapy, we've got perhaps our faint or dull erythema or some changes to skin pigmentation. Skin's all still intact. Carry on with your moisturiser and increase as required. Now, there is some recommendation in the Royal Marsden about the use of prophylactic barrier films, sprays or creams, but continue as above with the moisturising. Carrying on through the cycle, we've now got a bit redder skin, a bit brighter erythema, skin starting to feel a little bit tight, a little bit itchy, and possibly causing discomfort. Again, carry on with your moisturiser cream as required for comfort. The Royal Marsden does recommend at this point in their guidelines that PolyMem dressings can be used in the point of dry desquamation. They recommend dampening the dressing to aid as a pain control, so to aid discomfort in the skin. So your RTOG 2B, so we've come round our cycle and we've now got erythema, patches possibly of dry, but we've now got broken areas. So there may be some exudate leaking, very, very painful, very edematous, very inflamed skin. So the guidelines recommend that if the skin breaks, patients should be advised to discontinue any cream on broken skin and then obviously apply appropriate dressings. Now, in terms of dressing recommendation, again, this has all been taken from both those sources. The recommendation from the Society of Radiographer is non-adhesive dressings, silicone dressings, or low adhesive dressings, and obviously don't use any products with paraffin or petroleum-based within them. The Royal Marsden does continue to recommend PolyMem as before, and obviously if you've got areas of patchy, moist desquamation, areas of exudate leaking, edema around the inflamed skin, you can obviously apply the PolyMem dressings dry. So continuing to our RTOG3, lots of moist desquamation, more pronounced areas of broken skin, more pronounced areas of pale exudate leaking, very uncomfortable for patients, very painful, very edematous. Obviously, at this point, it may be that these patients need to seek further advice from specialists. So specialist practitioner within radiotherapy, tissue viability nurse, but again, continue with RTOG2B interventions. RTOG4, very rarely seen. I don't think I ever saw anyone with an RTOG4 when I worked at the Christie, but obviously from your observation, ulceration, bleeding, necrotic tissue, very, very significant in terms of skin healing and outcomes. And obviously your RTOG3 and 4, I mean, definitely 4 was where your treatment would stop. So let's have a look at the evidence. So the Society of Radiographers' most recent guidelines 2022 obviously wanted to look at new evidence, look at new research based on what they had previously looked at. And obviously, if you've ever looked at the guidelines, as I say, I know we've got some radiotherapy clinicians on the call. They're very lengthy, they're very good to read if you're struggling to sleep at night. But, you know, there's a lot of really good information there about promoting skin health, about maintaining skin health and trying to reduce the outcome and the severity of skin reactions. So multiple databases were searched to look for new research, look for new evidence around radiotherapy-induced skin reactions. So multiple databases, hand search of a number of relevant journals, supplemented by searches of grey literature. So they were also looking at any ongoing clinical trials. And the outcome was they found 33 studies, which is not a massive amount really, is it, when you think, you know, the number of years since the last guidelines were updated, but they found 33 studies for discussion. Obviously, all the included research was assessed for quality, with recommendations based on the studies as having low opportunity for bias, which is sometimes very difficult to find, studies that have got low opportunity for bias. As I said, ongoing clinical trials were listed, demonstrating a number of investigations that should be considered for any kind of inclusion in any future updates. So they used different tools to break down the literature. So they used the PICO method and the Pearl method to develop 3 overarching questions that they wanted to ask of the research. One of the questions was, is there new evidence to support the use of dressings, medical devices, oral medications, or barrier films to reduce the incidence of radiotherapy-induced skin reactions? I'm sure you probably all know the answer in your head at the moment. So one of the areas that they picked out to have a look at and see actually, is there any new research to improve skin integrity in patients undergoing radiotherapy? And one of the areas they looked at was barrier films. Now, it's important to note this relates specifically to barrier film dressings, as opposed to obviously what we may traditionally know as barrier films as our creams and film sprays. So in summary, in relation to barrier film dressings, the review team acknowledge how difficult it is to try and implement a strong research design when using a barrier film as an intervention. So, for example, our patients, so finding the most appropriate patients to match them to the treatment intervention. So are we finding the same groups of patients that we're going to use the same barrier film on? Well, no, it's really difficult to match the patients to the intervention to provide consistent research outcomes, because obviously we want to ensure comparability in areas covered by the film dressing or indeed not covered. Unfortunately, many of the studies reviewed in this section were considered to have some moderate or high risk of bias due to the confounding variables between obviously the treatment schedules, doses, fractions, patients, treatment areas, but there was also a high risk of bias. They also noted in the research that it was difficult to determine whether patients were also using creams alongside barrier films to be able to say whether one area was better than the other. They also noted that there was a really high rate of intolerance to the barrier film. So actually, patients were finding their skin becoming uncomfortable from the film adhesive as opposed to the radiotherapy treatment. So they were actually reacting to the shape of the dressing. Based on the research or the new research that the review team found, they do not recommend the use of barrier film dressings for patients undergoing radiotherapy. And they do recommend that further good level research should be done when looking at barrier films. As I said at the beginning, you could all be using really, really good barrier films and having really fabulous outcomes. This is only obviously presenting what the research shows us, so please do share with us. So obviously I've already mentioned the topical steroids at the beginning when we looked at the RTOG guidance, and this was one of the areas that the review team in the guidelines pulled out to have a look at some of the new evidence. They actually found that these studies relating to topical steroids actually had a low or moderate risk of bias. All samples involved in the assessment of steroid cream on patients were actually breast cancer patients, so patients undergoing radiotherapy for breast cancers. They did find some positive outcomes, but they also found it was variable in terms of the dose fractions in relation to what treatments patients were having, what dose treatments they were having. They did find some positive outcomes in terms of skin integrity, and as a result of this, they do recommend that there could be some benefit to patients undergoing radiotherapy in high-risk areas. So thinking back to some of those factors that we discussed at the beginning, those patients that are high risk of developing a high-grade skin reaction, so, you know, a category 2B or 3, those patients that we deem because of the treatment area, the treatment dose, or any comorbidities, then they did felt that there was some benefit to using prophylactic steroid cream. Interestingly, they also discussed PBMT. Now, I'd not heard of this before recently in relation to radiotherapy-induced skin reactions, because it is an emerging intervention. It's basically a technical term for low-level laser therapy. So it's a light therapy, either using laser or LEDs to improve tissue repair, reduce pain and inflammation. And it has been used for years on sports injuries, arthritic joints and back pain as a way of targeting below the skin surface to manage those areas of inflammation that are causing pain, particularly, as I say, in sports injuries and around joints. It has obviously been recognised in other areas of radiotherapy toxicity, such as the treatment of oral mucositis and lymphedema. But they do highlight that as this is an emerging treatment, and some of the studies show that it's been used successfully in terms of reducing inflammation, improving healing, certainly those ones that are getting earlier radiotherapy-induced skin reactions in their treatment. But as it's emerging, they do recommend that further research is needed in the area of PBMT to manage the symptoms of radiotherapy-induced skin reactions. So obviously, we've talked about film dressings with low level for recommendation from the research. We've talked about topical steroids prophylactically with some recommendation about improvement in skin integrity for those patients with higher risk. So let's talk about the dressings. Obviously, as I said, the guidelines from Society of Radiographers recommend low adhesion, silicone, non-adhesive dressings. The Royal Marsden online handbook does recommend the use of PolyMem. So let's have a look at PolyMem in the same train of thought as we have with some of the evidence in the Society of Radiographer guidelines. So a literature search performed using CINAHL, Medline, e-journals, online, ongoing clinical trials to try and establish. And I don't know whether that number will surprise you or not. It didn't surprise me, but I found 9 papers relating to PolyMem and the use of radiotherapy-induced skin reactions. So 1 article and 8 poster presentations. And what I've done is I've summarised some of the studies here. So obviously you can see in these studies, there's quite a wide variation in the number of patients involved in the studies. So, you know, down here with Hegarty and Wong, we've got 74 patients were evaluated. But then obviously in Monroe's study, there was 1 case. But I think it's really important to include all these cases because actually, when you look at what the the outcomes are for these cases, there are very, very reoccurrent themes that we draw from them. So the Bode and Woodman study, 40 patients, now this was a double arm study. So they identified the highest risk patients and they actually applied a barrier film spray or cream, so not like our film dressings. So they applied some form of prophylactic film or spray. And I do know that there are other products out there that areas will be using very successfully as a prophylactic treatment. So I know Flamagel XT is used in a lot of radiotherapy areas very successfully at reducing the severity of the skin reaction. But this study, they chose to apply a no-sting barrier film. They noted out of the 40 patients, 20 patients did go on to develop RTOG2B. All of these patients were then given PolyMem dressings. The themes from this study showed a reduction in pain, a gentle wound cleansing from the PolyMem group of patients, and they did note improved wound healing in the radiotherapy-induced skin reaction despite treatment continuing. 57.5% of patients expected to develop a radiotherapy-induced skin reaction didn't. So those ones that didn't need to go on and have PolyMem dressings, they didn't develop a skin reaction despite expecting that they would, despite identifying that they would be the category of patients that would after the use of the barrier film. The Vincent and Franco case, so 3 cases, not a massive group of patients, but they reported PolyMem use, showed a benefit of pain reduction, wound bed cleansing, debridement, and they felt there was faster healing. It's important to note that study, it's an oncology study, 2 were radiotherapy-induced skin reactions and 1 was a paediatric extravasation injury. Obviously, we've got the other cases, we've got Scott, again, the same themes, real dramatic reduction in pain, longer wear time of the dressing, increased healing rates when compared to standard treatment. And I think the other thing as well, patients and carers were able to change the dressings themselves. They reported a reduction in pain medication. And for me, one of the most important things that I think I got from this was all the patients said they could sleep again. You know, we take for granted, don't we, things like being able to sleep, things like being able to just sit down, you know, patients that have had perianal or vulval treatments, and they say, actually, I've not sat down for 3 weeks because the pain's so bad. So I think, you know, the fact that actually patients said, you know what, I got a full night's sleep, that improvement on that patient's quality of life, that's what it's about. That is what we hope for. Again, the Truman study talks about reduction of pain, improved skin healing. We've got the Monroe, that was done at the Beatson. So we've got any Beatson colleagues? I know we've got some Scottish colleagues on here. That was done at the Beatson. And again, they demonstrated a real good level of comfort achieved with PolyMem dressings, and they did actually introduce it as a wound care intervention for them. And then obviously we've got the Hegarty and Wong, so the bigger study in terms of patients, again, reported really positive outcomes in terms of patient comfort. They also highlighted improved sleepability, which, you know, they were able to demonstrate additional benefits over standard dressings. Interestingly, they did recognise challenges around dressing anatomically difficult areas. And if any of you are old enough to remember Blue Peter, although I do feel that Blue Peter's probably still been around recently, you know, from my Christie days, I'd dress an area and you'd be looking and thinking and you'd be like, yeah, I should get a Blue Peter badge for that. And I say that sometimes to younger clinicians who don't remember. I think they think I've gone mad, but sometimes it's really difficult, isn't it, to dress areas that are difficult anatomically, so penile areas, ears, head, those kind of things. So we do have a really good cutting guide that can support clinicians around dressing anatomically difficult areas. I'm just briefly going to cover the late effects of radiotherapy because although it's obviously unusual, I think it is something that when we're looking at skin changes, that it is something that we do need to consider. So we know that the onset of radiotherapy-induced skin changes can occur from 15 days to 10 years or more after the beginning of radiation therapy. And it's an extension of the acute process, involves further inflammatory changes to the skin. So chronic Radiation changes to the skin are characterised by difference of follicular structure. So I don't know if you can see this gentleman on the image. He's obviously got no stubble growing through on this side. So he's got lovely stubble and dark shadow, but obviously on this side where he would have undergone radiotherapy, he's had that damage to that follicular structure and pores and hair growth. So that's not the same. We know that there'll be an increase in collagen production, damage to the elastic fibres in the dermis. Obviously, we see changes like this, so telangiectasia, so those prominent sort of blood vessels that change. And we also know that secondary skin cancers are common on areas where repeated exposure to radiotherapy. So your basal cell carcinomas that develop on the skin as a result of obviously radiotherapy to treat an internal cancer or tumour. Excuse me. So, in conclusion, and I suspect that this was probably some of the thoughts we had at the beginning, which is why I'm being very passionate about encouraging you to share best practice, encouraging you to share anything unusual that you may have tried. We know overall that the evidence base is not strong enough to make very, very specific black and white decisions around particular products for topical application. However, we do know that us as clinicians, you know, we come into the job to help people, don't we? That's why we're here. So we come to make lives better. We come to look after people and make them better. But we also know that patients prefer to take action rather than doing nothing. So we know that the focus for skincare should be around promoting skin integrity, reducing that risk of radiotherapy-induced skin reactions, or trying to reduce the severity of that they are. But we also know that we should be aiming to alleviate symptoms. So those symptoms that we've already highlighted throughout this webinar: pain, inflammation, dry, tight skin, more pain, moist, leaking areas, risk of infection, you know, coping with a multitude of different tissue types at once. So the priority should be alleviating those symptoms and provide comfort. And we do know from anecdotal evidence, and also obviously the evidence presented from those small number of case studies, those 9 case studies, that PolyMem really is unique in managing radiotherapy skin reactions. We know that it's able to absorb the exudate from those patches of moist desquamation, those higher levels of exudate from that inflammation and edema in the surrounding tissues, just by nature of the treatment. We know that it can gently cleanse without us having to worry about cleansing the skin, cleansing the wound in between dressing changes. We know that it can donate the glycerol. We know that it can promote that lovely moist wound healing and moisturise those really tight areas that patients say feel tight and uncomfortable. And it's going to provide that thermal insulation. It's going to be able to provide a covering over that nociceptor activity, so that's that pain activity that patients feel. And that's what's important, isn't it? It's about improving patients' quality of life. Those of you on the call that are not familiar with PolyMem or maybe never used PolyMem, it's an absolutely amazing dressing. It's not a foam dressing, it's a polymeric membrane. And obviously the dressing needs to be intact with the skin to be able to absorb the exudate and obviously activate the glycerol and the surfactant within it. Obviously, I just mentioned about nociceptor activity, so wound pain, so nociceptor and inflammation. We could absolutely talk for hours on it, but we don't need to, because we've got an absolutely fabulous Facebook Live that Tammy did a couple of years back, which is saved on our website. Please do go have a look at that, because she does explain nociceptor activity in wound pain, how that obviously interacts with inflammation, inflammatory stage in wound healing, and then obviously how PolyMem is unique in the fact that it's got those individual components that I mentioned, so your surfactant and your glycerol, but also they actually work together. They're like a little team, and when they get together, they can do amazing things around managing wound pain and inflammation. Obviously, we've also got the patient information guides, we've got clinical user guides, and like I said, if you want to get your Blue Peter badge, you know, we've got cutting guides as well, and most of these are available as downloads off our website, or obviously you can contact us if you wanted any of the booklets, the cutting guides. So I want to thank you. I hope you're all still there, because obviously I can't see any of you, for listening. Please do ask questions. Please do share best practice, because as I say, we're so lucky in the amount of people that have come on the call. We are planning our next webinar, which will be the 27th of April. So it will be very similar to this. Likelihood it will be through Teams or a different platform. We will be sending out the information, and that webinar will be focusing on malignant skin and wounds. So you will receive information about that one, or obviously get in touch with us if you wanted to sign up for this. Obviously, there's a link to the references used within the session. So I'm going to stop sharing my screen and grab a quick slurp of my tea. Are there any amazingly wonderful treatments going on? Because I know we have got some of our radiotherapy colleagues on here. Are there any amazing new emerging treatments that you'd be happy to share with anybody on the call?
Hi, Sharon. I'm just looking at the questions that we've got. So there's no questions, and thank you for that, by the way. That was great. There's no questions specifically. It's more just sharing best practice in the chat, which is really
Brilliant.
Good. I think someone has mentioned about the avoiding the use of aqueous cream. I might have pronounced that wrong.
Aqueous
and using
cream,
emollient. Yeah, and using emollient instead. What's your thoughts on that?
Instead of using emollient over aqueous cream. Yeah, so obviously aqueous cream should be avoided. I know some areas still use it as a soap substitute, so not a leave-on emollient, they only use it as a soap substitute. I know some areas don't use aqueous cream at all and just use emollients or their own moisturiser. So patients that have moisturisers that they know they're happy with, and I think there's a comment from Beatrice. I was just having a quick look. As long as they've used the product before, fragrance-free, no parabens or nasties in there, then they're absolutely fine to continue with those products.
Fabulous, thank you. I don't think we've got any more questions in the chat, but honestly, don't be shy. If you have any, please do ask them. We will be, just while I'm talking, we will be sending across a feedback form afterwards. If you are happy to complete that, it'd be really useful for us. I've just seen a question asking, Sharon, what are your feelings on Flaminol?
Personally, I think Flaminol is a great product. As a nurse, I think Flaminol is great. Obviously, Flamigel XT and Flaminol are obviously different products made by Flen Health. Flamigel XT is obviously marketed by them as a prophylactic barrier to the skin to try and reduce the risk of skin reactions. Flaminol is obviously like an alginate paste. Yeah, I think it's a great product for wet exuding wounds, and I have used and still do use on my tissue viability honorary days Flaminol as a product. That's like asking a politician a question, isn't it, that?
Absolutely. And then we've just got, I suppose, an information for use on PolyMem. So am I right in thinking that you can dose sterile water on PolyMem prior to using it, which is correct, but I'll let you add anything that you need to.
No, obviously, as I say, from the Royal Marsden guidelines, they do recommend it can be used as to provide comfort from painful skin in sort of dry, intact skin. So yeah, you just moisten it as opposed to soaking it. So you literally just want to provide a little tiny bit of moisture just to activate the surfactant and the glycerol. But any patches of any moist desquamation, even if you think there's only the tiniest bit, you shouldn't need to wet it, because by nature of the membrane in the PolyMem, it will encourage that surrounding sort of fluid and inflammation out of that tissue.
Great, thank you for that, Sharon. And we have another question here about PolyMem. So are there any thoughts on changing the colour of the PolyMem dressings? I don't believe so, personally, but unless you know something,
it is
I
a
don't,
funny
Sharon.
colour, isn't it? No, and obviously, H&R distribute PolyMem. We don't make it. It's obviously made in the States. We're just more excited about trying to get different shapes and sizes. Well, I say we, that's the royal we. I would like to be able to get different shapes and sizes of PolyMem. But no, I don't believe there are going to be any changes to the colour of it. It is an odd colour, isn't it? It's not like a skin colour or anything, really. It's very bright.
Definitely stands out.
Yeah.
Okay, well, that's it in the chat question box then. So I don't think anyone's got any more questions on that front.
I think there was just a question, and apologies if we it's about sodium lauryl sulfate. So I know Beatrice said that was old guidance about not needing sodium lauryl sulfate free. I think that was relating to the fact that obviously patients can continue to use their own products as long as there's no nasties in. And Ericla has put, it's still recommended that sodium lauryl sulfate free products are used in the current 2020 guidelines. So has anyone got anything they want to add around the sodium lauryl sulfate query? It was just to make sure that we've kind of covered that. As far as I'm aware, the current guidelines, oh, here we go, what's Beatrice put? Sodium lauryl sulfate use isn't included in that guidelines. In the Long Society of Radiography Guidelines, they did a study and the difference is negligible. I suppose in terms of sodium lauryl sulfate products, you need to go with your own sort of guidelines and policies about what you follow in your trust. I thought that it mentioned in the Society of Radiography Guidelines about using SLS free, but I know Beatrice has posted a link, I think, to the recent guidelines. No, Claire has. Apologies, Claire.
We have had someone ask in the chat, Sharon, if you could briefly explain how PolyMem works.
How long have we got?
Yeah.
So PolyMem works by it's got, like, if you stretch the PolyMem, you can see it's kind of got open pores in the membrane. So it works by encouraging. So I always describe it dead simply like a pulley. I don't know if that's the right sort of definition really, but I like to use simple things to explain. So like a pulley, so it will encourage. So it's got like we see like in honeys, that osmotic pull, it will encourage exudate into the dressing. So that's why I said, even if you've got a very small open area, you know, the PolyMem will encourage that wound fluid, that tissue fluid in the inflamed tissue into the membrane. By doing that, it activates the surfactant. So if ever you've felt a wet PolyMem kind of like that between your fingers, obviously, you know, a gloved finger, if it's a one that's been on a wound, you'll feel the soapy, you'll feel the surfactant, and you'll look at your finger and see the shine of the glycerol. So by actively encouraging the exudate into the membrane, it then donates the surfactant, it will gently cleanse, so it's continually working like that. It will then draw back in any debris that it's debrided. It will donate its glycerol to make sure that it's moistening. It's providing that thermal insulation to expose nerve endings, and it continues. So it's an active dressing, as opposed to, obviously, we know foam dressings are there to absorb exudate into the core, lock it away, and obviously protect any external contaminants. It actively knows that it actively draws, like it has that pull into the membrane. I could talk for ages on PolyMem, but I'm conscious of the time.
Just quickly then, Sharon, how long can you leave it on the wound? Because Edward has mentioned here that the patients throw it away daily.
So, I mean, it may well be, Edward, are those the patients that are obviously having treatment daily? So are they going for the radiotherapy? So it's licensed to stay on a wound for up to 7 days. I think there was a question about prescribing as well.
Yeah.
So it's licensed to stay on a wound for 7 days. But obviously, if the patients go in and having daily radiotherapy, then they will be taking it off for the treatment. Claire's asked, can it stay on the skin during treatment? So no, it can't stay on the skin. So that may well be why patients are obviously throwing that dressing away daily. I don't know what other people think in terms of, we use the roll, so we use the long, the 10 by 61, I want to say, centimetres. So we would obviously, patients would cut a piece off. I'm going head and neck because that's obviously one of the main areas. They would obviously cut the piece off that they needed. That would then go in the bin when they went for the treatment, and then when they would cut off a fresh piece. So no, 7 days license, but depends on the level of exudate, the tissue type, and whether the patient is undergoing treatment, and it can't stay on the skin during treatment. And I'm not aware that there's been any, you know, it's quite a thick membrane dressing. I know some studies have been done looking at bolus effect through very thin dressings, but certainly not PolyMem. It needs to come off the skin for the radiotherapy. Oh, you've just been stopped, Edward, from ordering your roll by the hospital. Oh no, because actually that's sometimes more cost effective than ordering like your 10 by 10 or, you know, your square sizes, particularly for your head and neck patients. Julie's asked a really good question, actually. I've just seen that, sorry. We know, yeah, what a shame. Head and neck patients, do you wrap it all the way around? So when I use the 10 by 61, so obviously cut the piece that the patient would need, we know obviously that tapes and stuff like that, adhesives, can't go on the skin, because we know that actually that area of skin's really fragile undergoing the radiotherapy. When I used to do it, I used to fold I wish I had one with me, the roll in half and put little splits, just so it gives some flexibility on the neck. And then obviously you don't want to cause any constriction. By putting your little slits in your PolyMem, you will get a little bit of flexibility. And then generally you can stick the tape to the other piece of PolyMem. So if you had your roll all the way around with your little tiny splits in it, your patient's able to obviously move. It needs to be nice and secure against the skin. I used to go on the ward sometimes and see patients with the PolyMem down here worn like a scarf. Well, obviously that's an expensive dressing that's having no effect if it's not right against the skin. But generally it's better to pop a little bit of tape on the PolyMem dressing at the back.
And can you reapply the same dressing after treatment if it looks clean and is kept?
Well, I wouldn't do. I'd be putting a clean piece on. Don't know
Yeah,
what everyone else thinks about that.
Yeah, would definitely recommend putting a new dressing on for that.
Yeah. Thanks, Julie. That's a really good question, though. Oh, sorry, Claire. I didn't see you with your hand up. Little bottom Claire at the picture. Yes, you can. Oh, bless him. Yeah, no, you can drop me an email, Claire. In fact, let me pop my email in here. I think most of you've got it.
If anyone has any product queries as well, feel free to just email marketing at HR Healthcare, and we'll be able to get back to you on that as well.
I think I've answered everyone's questions. I know obviously there's probably some debate about the sodium lauryl sulfate, but like I say, go with your local guidelines. And I am going to have another look at the Society of Radiographer guidelines about that myself. But yeah, have a little look yourselves. And as I say, if there's anything that I've missed or anything specifically more that you wanted, then please do drop me an email and we can get some more information for you.
We have got Aaliyah Cox with her hand up. I don't know if she's wanting to.
Hi, Leah.
Hi, Sharon. Hi, just a quick one. Do you have an audit tool that you could send us? So if we were to structure an audit, that we've got some sort of structure that PolyMem have used before, whether it's using photo befores and afters.
Yeah. So we've got what's the word I'm looking for? We've got evaluation tool documents that we can use. So obviously for doing sort of clinical evaluations, we've got really lengthy documents, Leah, that will capture all the same kind of information for all your patients. So we can certainly send you those. And then we can help if you wanted, if you wanted to do an audit looking at specific areas for your radiotherapy patients with PolyMem. We can look at the data, obviously anonymize it, but we can help support you look at that data as well, if you want us to.
Great, thank you.
But drop me, I think you've got my email address anyway, Leah, because I think I've seen an email off you. But yeah, drop me an email and I can send you those evaluation forms. That's not a problem.
Lovely, thank you.
Thank you so much, everybody, for taking time to join this and absolutely being really engaging. Claire, of course you can. Yeah, stay on, Claire. Thank you. I know we might have run over a little bit, but I think there's been some really interesting conversations, questions, and thank you, everybody. I was a little bit scared when I saw all your names because we've got some amazing clinicians on here. I was emailing Laura, threatening her that I was never doing it again.
Well,
right, thank you, everybody. I'll let you all go. Please do get in touch with me if you wanted any more information. And I'm just going to hang on for 2 minutes with Claire.
All right. Thank you, Sharon.
Thank you, everyone.
Thank you.